I just did that.
Thank
Okay.
you. We've got that covered now. Thanks so much.
Okay, sure. So there's a word dominance in coronary arteriography. Which is the dominant coronary artery? Well, 80% of the time, it's the right coronary artery. And what determines which coronary artery is dominant? Well, it's that artery that feeds the PDA. So let me go back. PDA meaning the posterior descending. I wonder what's made it not your screen sharing. I wonder why I can't go back. My goodness, start the video. Go back. No.
I wonder if you click on the left side onto
I'll do that. I'll do that. Okay, that worked. So here, the right coronary artery comes down. This anterior atrioventricular groove goes into the posterior atrioventricular groove. And if it's dominant, it feeds the posterior descending. If the circumflex is dominant, which is only 20% of the time or so, it goes down, feeds that posterior atrioventricular groove and down into that posterior descending. So that would be a very large left coronary artery that feeds the anterior descending and just about, the anterior and posterior descending. But the majority of the time, it's the right coronary that feeds the posterior descending. So 80% of the time. Now, the first branch of the right coronary artery is usually the branch to the SA node. The next branches are branches to the right ventricle, which I just defined for you earlier. Coming from this crossing point, which in Latin is called the crux, C-R-U-X, it's the crossing of that posterior descending and this posterior atrioventricular groove. From that point comes the artery to the AV node. And it's the origin at that crux of the posterior descending. All right. I already talked about the septal perforators coming down from the LAD or up from the posterior descending. And what's their importance? Collateralization in case one vessel, the anterior descending or the posterior descending, is occluded, it will prevent ventricular septal rupture. All right. The right coronary artery usually supplies these areas. And when that happens, when there's an occlusion, depending upon the level, it'll cause something that you could notice on the electrocardiogram. So if you notice that there is sinus node dysfunction or sinus arrest, and we know that that first artery comes right proximally from the right coronary artery to the SA node, it's a very proximal right coronary stenosis. If you've got a right ventricular infarction, it's quite proximal in the right coronary artery as well, because these are where the vessels to the right ventricle come off. I just told you that the artery to the AV node comes off of the crux. 80% of the time, it's the dominant right that does this. So it's a more distal occlusion in the right coronary artery that'll cause AV block. And more distal than that, if that's the only thing you see is an inferior or infraposterior infarction, that's more distal in the right coronary artery. Now, let's say you see every one of these things. Well, then you've got a very proximal occlusion in the right. Now the button works. So how about the left coronary artery? Well, anterior or anteroseptal myocardial infarction, that's from the left anterior descending. Depending upon where in that left anterior descending the occlusion occurs, it would be an anterior or an anteroseptal infarction. I think it's important for you to know this. The anteroseptal infarction is when the occlusion in the LAD is proximal to the first septal perforator. And on the EKG, you'll get a Q wave starting in V1. However, if it occurs, the occlusion, after the first septal perforator, then it will be an anterior infarction, and the first Q wave will not be in V1, that will preserve its R wave, but the first Q will be in V2 or beyond. Okay, so how about if you've got high-grade AV block, which is just about third-degree AV block altogether. Occasionally, a beat gets through to the through the AV node to the ventricle, that's the His bundle, and that's from the left coronary artery 75% of the time. So if you see third degree AV block, it's usually the left coronary artery that's obstructed. And if you have a posterior or lateral infarction, that's from the circumflex. And if you have a bifascicular block, the most common one, right bundle branch block and left anterior fascicular block, then that's from the left coronary artery the majority of the time. It's very difficult to get a left posterior fascicular block because it has dual circulation that is circulation from each coronary artery. All right, let's talk about coronary arterial supply. We mentioned it's epicardial. The vessels flow on the surface of the heart, and it finds its way through the myocardium. So the endocardium, that which is closest to the pumping chamber, gets its blood supply last. Now, that doesn't really make quite as much sense as diastolic blood flow in the coronary arteries does to me, because the pressure is higher there. But that's the only way it is. What decreases this supply? Coronary atherosclerosis, coronary spasm, including Takotsubo disease, which we'll discuss, elevated end diastolic pressure that I just mentioned, anemia. You just don't have enough boxcars to carry that oxygen around, so it's got to run the track more often. Hypoxia, either from ambient air or from lung disease. That will decrease the oxygen supply. Or acidosis. Now, be that acidosis from lactic acidosis or from ketoacidosis, decreases the supply. About demand. Well, if you don't know anything else about myocardial oxygen demand, it's determined by heart rate. That's why when we do treadmill tests, we monitor heart rate. If you want to stop a treadmill test to stop a patient from having chest pain or electrocardiographic changes, you just ask the patient to step off the treadmill and the heart rate will slow and the demand will decrease. What else are determinants of myocardial oxygen demand? So contractility, that is the ability of the heart to eject against an arterial pressure with an end diastolic volume, or wall tension of the ventricle based on wall thickness, ventricular radius. So a big radius takes a lot more oxygen demand, and increased intraventricular pressure. So what happens when demand exceeds supply? Well, in order of severity, there's ischemia, then injury, and then infarction. So here's my first kind of sick joke. We must learn to read EKGs with 3 eyes. All right, so let's look at the cardiac action potential together with the electrocardiogram. They're both on the same x-axis. So on top is the cardiac action potential of a single cell. And there are phases 0 through 4. 4 is resting. The resting potential is negative, minus 90 millivolts. But during phase 0, when cations, sodium and calcium, positive charged ions, enter the cell, you end up getting a bit of a positive charge. And then after phase 1, you have essentially 0 polarity. So you go from negative polarity to 0, depolarization. That's the source of that term, depolarization. And during that same time on the EKG, you see the QRS. So depolarization is the QRS, and that's when the heart contracts. But this is the this is the movement of ions that in the cell that makes that contraction and shows up on the EKG as a QRS. Then during phases 2 and 3, we have repolarization. And by the time we reach phase 4 again, the polarity is minus 90 millivolts. So we have ST and T waves. At the time, we have repolarization. And so any change in the timing of the repolarization changes the ST and T waves. And this could be due to medications or ischemia or whatever. Okay. So of course, during ST and T, we have relaxation of the heart. What's the path of depolarization through the ventricles? We've got the anatomic structures that are most important, color-coded here, but we start in the ventricle. So we've already been to the SA node and the AV node and the His bundle, and now we enter the ventricular septum. We've got the left bundle branch and the right bundle branch block, and they carry the electricity much quicker than if it was going to go from cell to cell. It then enters the Purkinje fibers in both ventricles and out into the walls of the heart. So then that can start the contraction in kind of a synchronized fashion. So let's talk about depolarization and repolarization electrocardiographically now. So during depolarization, Purkinje fibers carry a wave of positive charges from endo to epi, just the opposite direction from the blood supply, which goes epi to endo. But if the charge is coming towards a lead, that positive charge, an R wave is inscribed. But if there's dead myocardium, that positive wave has to move away from that area. It can't go towards it. And a Q wave is inscribed. So R waves and Q waves have to do with depolarization. In repolarization, if you have ST depression, that comes from subendocardial ischemia. If you have ST elevation, it comes from subepicardial injury or infarction. So there are our three I's. All right, let's start with a description electrocardiographically and a definition of ischemia. Inadequate blood supply for a given activity. On the EKG, there's ST depression, often with T wave inversion, but no Q waves and no troponin. Look at the ST segment depression. The most important determinant of this ST segment depression is heart rate. Now, if this were sinus tachycardia, you'd tell the patient to step off the treadmill and it would resolve. But this is an arrhythmia. So you're going to have to treat this in a different way. But the point remains, tachycardia increases the demand and the supply just can't keep up. So this is ischemia. All right. How about injury? Death of myocardial cells with release of troponin into the bloodstream. The EKG shows ST segment elevation, but no Q waves. So this is a hyperacute anterior infarction. No Q waves yet. Remarkable ST segment elevation. And do you see the fireman's hat? So look in lead V2. Here on that baseline is the front brim, and then here comes where the shield is, and then that ST elevation is where the dome of the hat is, and coming down here to the T wave would be where the posterior brim of the hat is that keeps the hot ash from going down the firefighter's neck. So this is injury. No Q waves, but there is troponin and ST elevation. How about infarction? Now, this is beyond what we have just seen. Abrupt occlusion of an epicardial coronary artery, usually at the site of an atherosclerotic plaque rupture. Thrombotic occlusion results. Troponin is released, but it doesn't last forever, only lasts for a few days. And so do the electrocardiographic changes. That ST elevation ends up becoming Q waves as the ST segments return to baseline and the T's right themselves back up. So we see Q waves in 2, 3, and AVF. And we see early R wave progression in V1 and V2. Usually it's not until V3 where the R wave exceeds the S wave, but this is a posterior infarction. So this is a remote inferior posterior infarction. Is there troponin at this moment? No. Is there chest pain at this moment? No, but there was. So this is a remote inferior posterior infarction because of the Q waves, and what is the equivalent of a Q wave in the posterior leads a tall R wave with upright T wave. All right, let's look at some unknowns. So here's a 49-year-old man with months of indigestion. Well, he tried antacids and they didn't work, and he got kind of a little bit unhappy with his own medical treatment, so he sought attention. Well, an electrocardiogram was done, and it showed tall R in V1 and V2 with upright Ts. The ST segments were back to baseline. There was no chest pain at this moment. This is a remote posterior infarction, just like the one we saw before, but without the inferior aspect of it. So this is infarction. Indigestions because that posterior wall is right on the diaphragm. And it's hard to differentiate indigestion from posterior wall injury infarction if you've not been through it before. All right, here's an 87-year-old man with chest pain and dyspnea. Always listen to all the symptoms. The chest pain is due to ischemia, ST depression, rather impressive. Tachycardia, rather impressive. Sinus rhythm for sure. But because of this amount of ischemia, there's also ventricular ectopy. And there's one other feature that's very important here. ST elevation in AVR. So the combination of large amount of anterolateral ischemia with ST elevation in lead AVR adds up to left main coronary artery before the branches stenosis. And so this patient gets stabilized. The dyspnea comes from increased end diastolic pressure, which backs up into the pulmonary veins and causes dyspnea. So if the blood pressure will tolerate it, you can slow the rate, give some diuretics, take the patient to the cath lab. All right, here's a 45-year-old man with an acute chest pain. This one's kind of easy as well. We've got ST elevation in lead 1 and AVL, reciprocal changes in 3 and AVF. We still have a little R in V1, but we start with a Q, a little Q here in, or what looks like the place where the Q will start. So this is an anterolateral injury. No Qs just yet. What is the distribution in the coronaries of this? It's probably in the proximal to mid left anterior descending, just before a diagonal branch of the left anterior descending, which feeds that lateral wall. So this is injury. Yes, there'll be chest pain. Yes, there'll be troponin. And yes, you should do something to try to prevent this from becoming an infarction. All right. Here's an interesting case, a 75-year-old female with chest pain and a new diastolic murmur. How do we know? You say, do you always have a murmur, ma'am? And she would say, no, I was never told that. So which eye pertains here? Well, we've got ST elevation and T inversion. No Q waves. It's rather diffuse. It starts in V2 and goes to V6. Also involves here 1 and 2. So let's take a look further. So this is the same lady depicted by the Japanese. And it always, almost always occurs in elderly females because perhaps they're just more prone to vasospasm when they get upset. She felt trapped, just like this taco, this octopus in Japanese, in the subo, which is an octopus trap. And the Japanese named this taco subo because this pot is what the left ventricle looks like when it contracts echocardiographically. We'll talk about the murmur in a moment and treatment in a moment. So if we look at this pot, tsubo, as on a clock face, say the center of the clock is here, this would be 5 o'clock. Let's move that pot around to 9 o'clock. So it'll be parallel to the bottom of the screen. That's the image of the ventricle of a patient suffering with Takotsubo disease on a parasternal long axis image by echocardiography. The base of the heart will contract, but when it contracts, the apex and the anterior and inferior walls will bulge. Not much blood pressure results in tachycardia, and that increased velocity in the contracting base of the heart causes a murmur, and that increased flow there creates a Venturi effect that sucks up the anterior mitral leaflet and causes posteriorly directed mitral regurgitation. Boy, this sounds a lot like hypertrophic obstructive cardiomyopathy. But if you treat these patients with some sedation and calming conversation and beta blocker, which will slow the rate, the murmur will abate and disappear as the heart rate decreases and the vasospasm relaxes. Now, the EKG doesn't normalize in the day. It takes, a couple of weeks to return to normal. There will be troponin, so this is injury. There won't be Q waves if you take care of this properly. And the ventricle will return to normal echocardiographically and symptoms as well within a couple of weeks as well, in most cases. Takotsubo syndrome. All right, here's a 45-year-old man with acute chest pain and hypotension after receiving sublingual nitroglycerin. The patient was seen in the field. The chest pain was impressive. The electrocardiogram was obtained, showed what looked like an inferior infarction, and sublingual nitroglycerin was given. But there's one more thing on this. Well, there's two more things on this electrocardiogram. Look at the tremor artifact. And look at the ST elevation in V1. Now, this is standard left-sided precordial leads. Well, when this electrocardiogram was brought to the emergency room where the patient was seen next, the patient was warned. When the patient received the sublingual nitroglycerin, there was almost instant hypotension and lots of room temperature saline was administered, 2 liters worth, and the patient started to tremble. Well, warm blankets and changing the left precordial leads to right precordial leads showed that the ST elevation in V1, when it was left precordial leads, is now in V4 and V5R and V3R. This is right ventricular infarction. It's always in association with an inferior infarction, just about. Reciprocal changes laterally. Sinus rhythm with first degree AV block. So we've got a proximal right coronary artery occlusion here, enough to cause the inferior infarction, some effect in AV conduction, and a right ventricular infarction. Well, why do these people get hypotensive? Well, they become hypotensive because the right ventricle is not contracting. And if you vasodilate, then there's nothing to get the blood to the lungs and nothing to get the blood back to the left ventricle to pump for systolic blood pressure. So volume is the treatment for this patient. So raise all the pressures, those neck on the right, so that you can push some blood out to the lungs. Remember, if you see that electrocardiogram, I think it is this one, with left-sided precordial leads in the field or anywhere with ST elevation, You don't want to give sublingual nitroglycerin. This patient should go to the cath lab to see what you could do to open that up. All right, another case, 47-year-old man. 2 questions. First, where are the myocardial infarctions? Okay, Q waves inferiorly. ST segments are back to baseline. Reciprocal changes, not ST segments, just T waves that are kind of inverted. So there's an inferior infarction. Remote. How about looking here? You've got Q waves in V1, V2, V3, V4, V5, and maybe a tiny one in V6. This is a large anteroseptal infarction. If it were anterior, you'd keep your R wave here, and the first Q would be in V2, anterior infarction. So anteroseptal. Now you say, well, look at that R wave there. Well, this is right bundle branch block with an S wave here in lead 1 and in V6. So this is really an R prime. The first R is lost to a Q wave. And the repolarization changes of right bundle branch block are what makes that T there. But then where is the aneurysm? Well, there's ST elevation in V3 with a Q wave, remote from the pain. This is aneurysm in the anterior wall. Why do you care about that? Well, there are 3 things you need to look for with an aneurysm. You're looking for ventricular arrhythmias, you're looking for heart failure, and you're looking for thrombus formation and embolism. So be careful when you see an aneurysm. Those are the 3 things that are most important. All right, here's another mimic. This is an 80-year-old female treated for atrial fibrillation. And Laura and I were just talking about this drug a little bit earlier. Why is there such ST depression? It looks kind of like concave ST depression in all but AVR and V1. Here it looks like convex ST elevation. Well, there's no longer atrial fibrillation. This is some type of supraventricular rhythm that's regular. It's not sinus because the P wave axis isn't sinus. It's, let's call it ectopic atrial rhythm. But the patient's doing great. The EKG shouldn't make you think there's ischemia. And you shouldn't think it's digitalis intoxication either, because the electrocardiogram of digitalis toxicity is increase in automaticity of the atrium, which you don't see. The ventricle, ventricular ectopy, you don't see. Sometimes you get AV block. You don't see that. And you can ask the patient, are you nauseated? How's your appetite? Do you have a bellyache? Do you have funny vision? And if all those are negative, you can forego the blood test. But if you're concerned, you can draw a digoxin level. All right, another mimic, 82-year-old female with severe headache. This is Cushing's reflex, which is bradycardia, increased systolic pressure in the presence of increased intracranial pressure. Well, look at the location of this patient and look at the symptoms before you read the EKG. Make sure that if the patient's in the neurosurgical intensive care unit or has a headache and no chest pain, that these ST elevation T inversion changes shouldn't be read as ischemia, but you should say, does this patient have intracranial disease? If you were to decrease the intracranial pressure, you'd increase the rate, drop the systolic pressure, and gradually the electrocardiogram will normalize. All right, another mimic of the 3 I's. This one you might recognize right off the bat. It's a patient with chest pain. You see there's ST segment elevation, and the T waves are still upright, different from what you'd see in ischemic heart disease, where when you have this much ST elevation, you've already started to get some T wave inversion, unless it's really that fireman's hat a little bit earlier than what we showed you. But you can do one thing to help you with reading your electrocardiogram. You could take out a stethoscope if this were your patient, and put the diaphragm on the chest, turn the patient to the left, ask the patient to take a breath if he could, and you'll hear a pericardial rub. Now, it won't be the same pericardial rub that you're used to hearing. The usual pericardial rub has got three components. It's got a atrial systole, ventricular systole, and ventricular diastole. But here, this patient's in atrial fibrillation. You're going to miss the atrial systole and only have ventricular systole and ventricular diastole. So here's my second bad sound. The normal or the usual three-component pericardial rub sounds like it's regular because there's sinus rhythm and there are three components. But this patient will have an irregular two-component rub. It'll sound like your stethoscope will help you read this EKG and diagnose the patient. All right, we've gone over this before. This is an 82-year-old female with chest pain after a PCI. Well, the PCI was in the right coronary artery, and it was very effective in preventing her from having any more ischemia when she would exercise. But it jailed a right coronary artery branch that fed the right ventricle. Here's left precordial leads, right ventricular infarction. Here's the electrocardiogram that she had before. There was no right ventricular infarction. This is before the PCI. And there was no inferior infarction either. But when the patient complains of chest pain after a PCI, do an EKG and do what's right. Take the patient back to the lab and see if you could unjail that right ventricular branch. All right, here's a 20-year-old female. Irregular pulse and episodic tachycardia. You look around and you say, wow, this is a 20-year-old gal. This is not a very normal EKG. Episodic tachycardia. Let's see. We got a sinus beat. We've got a premature atrial contraction, looks like. Sinus, PAC, sinus, PAC. So here's a pair. I wouldn't call that tachycardia. And another pair at the end. Well, there's a short PR and a delta wave and repolarization changes. Yes, this is WPW. And the episodic tachycardia is probably reentrant tachycardia that uses the bypass tract and the AV node. So, yeah, this needs further investigation if it's troublesome to her. All right, another case that we've seen before, but a different patient. 75-year-old female with chest pain and pulmonary edema. The last one we saw had dyspnea. Well, there's some remarkable tachycardia and some remarkable ST depression. And there's also remarkable ST elevation in AVR. Yes, this was left main trunk stenosis. Yes, there was ischemia sufficient to make the left ventricle dysfunctional and enough to back up into the lungs and cause pulmonary edema. Well, this patient had to be stabilized with diuretics and rate control and then taken to the lab. Unfortunately, she didn't have something that could be easily balloon dilatable. So she went to coronary bypass surgery. And here's her post-bypass surgery EKG. The ischemia is gone. All right, another take on WPW. Intermittent chest pain. Some people can't differentiate between ischemia and the conduction of electricity through the heart. So here's a patient who intermittently has WPW. Normal conduction, no repolarization changes. Then, without changing the rhythm, sinus throughout, no change in rate, we've got a delta wave and repolarization changes for 1, 2, 3, 4, 5, 6, 7, 8, 9 beats. Then goes back to normal conduction for a few beats, 2 beats, 3 beats, and then back to the pre-excited for 3 more. Well, you say, well, okay, that's a delta wave. But take a look in lead 1 and AVL. The delta wave is a Q wave. And in lead V1 and V2, it looks like an R wave. So it makes you think that this is a lateral posterior infarction. Well, not when from beat to beat, it goes from normal to that. So this is intermittent WPW. And be careful, if you're doing a treadmill test on someone and you're looking for ischemia and you find these kinds of ischemic or ST changes, repolarization changes, you say, this must be WPW. That's intermittent. All right, here's a new patient that comes to see you, 72-year-old man. Says he's got a history of hypertension and coronary artery disease and an old stroke with sequelae, and he's shaken to show you. And you can see the tremor artifact just in the limb leads, not in the precordial. And so there's the stroke with sequela of a tremor. Then you look for Q waves and ischemic changes, and you see an inferior infarction. Not having chest pain now. So there's the coronary artery disease. And you look over here in these lateral precordial leads, and you see large voltage and repolarization changes that look like left ventricular hypertrophy. So there's the hypertension. So you get quite a lot of mileage out of an electrocardiogram when you know what you're looking for. All right, here's a 22-year-old female with diabetic ketoacidosis. We talked about acidosis decreasing supply of oxygen to the heart, even though the blood's going through. Well, you can see there are ST changes here in the anterior leads. Well, we asked the gal, do you have chest pain? And she looked at you like, I'm having a hard time breathing, so I don't know anything else. And anyway, people with diabetes are usually not very good at telling you about chest pain. You know that. Some of them don't come in with the heart attack. They come in with the heart failure that results. Well, we treated her DKA, and her follow-up electrocardiogram with a slower heart rate was normal. And we took her to a treadmill test, and she did just fine with no ischemic changes. So DKA can decrease, acidosis can decrease the oxygen supply to the heart and cause those changes. All right. This 54-year-old man was managed prior to the thrombolytic therapy era or acute PCI era. And this was the EKG that I grew up with in myocardial infarction patients. They came in, even if they came in early, there wasn't much we could do for them other than heparin and slowing down the heart rate and giving them a little bit of dark room and no interruptions. And notice what's happened here. The patient's got an anterior infarction, not a septal, anterior infarction. Involves the lateral wall as well. And you see that there's tachycardia because there's so much myocardium that's been injured and that there's just no pump. So you need increased heart rate to maintain cardiac output. This person goes on to big trouble. Right? If you could do something to open that vessel, you could save some myocardium. But in those days, it was not possible. We're really fortunate today, both patients and caregivers. All right, here's another reason for T wave changes that makes you think of ischemia, but when it follows a left bundle branch block without any change in rhythm, well, then this is called T wave memory. So you go from a left bundle branch block conduction to a narrow QRS conduction, and in the anterior leads, there's deep T wave inversion. You can see it best here. It's not in this beat or this beat, but in all the others, the T's are really impressively different. That's not ischemic. That's just T wave memory, and you should recognize it and not react as if it needs to take the patient to the cath lab or anything like that. Another situation where you'll see this is when you have a right ventricular pacemaker that paces with a left bundle branch block type pattern. And when the pacemaker is either slowed or something allows the intrinsic rhythm to take over with a narrow complex, you'd get the same T wave memory. All right, here's our last electrocardiogram. 83-year-old man. That really gives us a lot of detail about left bundle branch block. So we start out with left bundle branch block, and we notice that there's ST segment elevation in 2-3 and AVF with T inversion. Well, in the inferior leads with a right bundle branch block, you just need 1 millimeter of ST elevation to call an acute inferior wall myocardial infarction in the presence of left bundle branch block. But if there were ST elevation in the anterior leads, well, then it would have to be 5 millimeters in order to call an acute anterior or anteroseptal myocardial infarction. And these are the Scarbosa criteria. Well, there's increased ventricular ectopy because of this inferior infarction. And after the premature ventricular beat, out comes narrow QRS conduction. And what we find is that the patient has large voltage and repolarization changes of left ventricular hypertrophy. Now, if the patient were to have left bundle branch block throughout this recording, you would never be able to call left ventricular hypertrophy because in the presence of left bundle branch block, there are no criteria for diagnosing left ventricular hypertrophy. So this EKG gives us lots of the detail about left bundle branch block and what you can and cannot diagnose and how to diagnose it. So the EKG, if you learn it well, you'll know the heart. And I'm giving you this lecture today, of course, because I want you to know electrocardiography as well as you can. But I also, in addition to hoping that you enjoy the lecture, I want to tell you that this covers just 2 chapters of 22 chapters in this EKG Learn It Well program. When you join the APAC, as a gift, you'll receive a subscription to the EKG Learn It Well. It's a $99 value, and it's one more reason to become a member of the APAC. So if you're not a member, join and tell your friends. It's a good deal in many ways. Well, I'll be happy to answer any questions, and I'll stop sharing.
Thank you, Dr. Schiavone. What a great presentation. We are so delighted to have you come back to APAC and share all of your wisdom over the years. If those of you who have questions, please type it in the chat. I'm trying to figure out how to let you talk on here, but it looks like that capacity is not available. So if you type it in the chat, I'm happy to verbalize those questions. As we're waiting for any questions, I did want to take an opportunity to those of you who logged on late to, yes, again, thank you for joining us, but also let you know about all of the benefits of joining APAC. So not only do you get access to the 22 chapters of EKG Learn It Well, you also have a chance to join separate committees. We have everything from electrophysiology, structural heart prevention, vascular disease, and we would love for you to join us. Please reach out if you find an opportunity you want to join or are interested in connecting with one of our committee chairs. We also have our in-person conference in Orlando, CAPSAP, the Cardiology and Pulmonary Summit for APPs, September 8th to the 10th. And in the follow-up after this, you will receive a link to the recording as well as an evaluation to get your CME. So please fill that out. And before we wrap it up, it looks like there was a question from Vanessa. Can you speak more on T-wave memory? What a great question, because I haven't heard it phrased that way, but I think it's a good question. So Dr. Schiavone, please enlighten us on this T-wave memory.
T-wave memory is something that is seen in largely two different settings. The most common that you'll see is like the electrocardiogram I showed you. That starts with left bundle branch block, and something usually rate related will change the duration of the QRS. And it goes back and forth between wide QRS complex and narrow QRS complex conduction. And in the process, the T waves will change like that. It has nothing to do with ischemia, and it really does not have anything to do with repolarization, other than the terminology memory is because now the repolarization is different. And so during those phases 2 and 3 of the action potential, there's a change compared to what is seen during left bundle branch block. It's also seen in right ventricular pacemakers that have a left bundle branch block pattern. If you look at EKGaction.com, my website, and you look for a demonstration, I think you'll see a case of T-wave memory that has multiple follow-up electrocardiograms, and you could learn a little bit more about it there.
Wonderful. We have just a few minutes left if anyone wants to type in a question. And Vanessa replied, thank you, Dr. Schiavone, for that great explanation. We are just, again, so thrilled to have you present again and also have all of you join us. We are excited to grow our membership and continue to offer opportunities for these types of free webinars and learning. Anything else to wrap it up, Dr. Schiavone, from your end?
Well, I know that we're not as interesting maybe as the All-Star game, but I think we've hit a home run.
Well said. Well, thank you again. Please all look for that link for the CME credit and evaluation, and we will send the recording as well to those who would like to have that for future reference as well. Thank you again for joining us, and I'm happy to sign off 1 minute early. Thanks again and have a wonderful night.
Thank you, Laura, very much for inviting me.
Yes, and Dr. Schiavone, if you want to just push the record button again, it will stop recording.
Let's see.
Should be along the
Oh,
bottom.
stop recording. I see it. Yeah.
And then there will probably be a pop-up that says, would you like to save this recording?
It says, are you sure you want to stop recording to the cloud? And
Yes.
that's the only thing I can say yes to.
Yep, I go ahead and do